Well, thank you. Oh, there we go. Thank you for joining us today. I'm really excited about our topic. I hope you are as well. And I know that we have a number of folks who are coming in, but we only have 30 minutes. And this is an important weighty set of issues we're going to be talking about today. So tell you a little bit about myself. I'm Dr. Abdul Sheikh. I lead Population Health Analytics for Worldwide Public Sector Healthcare Industries team here at AWS. One of the hats I wear also is I get to help coordinate our work with Dr. David Ansell and his team at Rush University Medical Center. Dr. Ansell is Senior Vice President of Community Health Equity at Rush University Medical Center. And the other hat I wear, which probably intersects, David, with your work, is around my role as a reviewer for the AWS Health Equity Initiative, which we're going to talk a little bit about later. I'm also really excited to introduce Dr. Reed Tuckson. And so Dr. Tuckson and I, we know each other through my affiliation with Academy Health, which is a health services research professional organization. I'm co-chair of their Diversity, Equity, and Inclusion Working Group. And Reed and I both have multiple other intersects, but I think for your reference, Reed is co-founder of the Black Coalition Against COVID. He is also co-chair of the Digital Action Collaborative for the National Academy of Medicine, and he's a former executive VP, Chief of Medical Affairs for the United Health Group. We don't have this here, but he's also a former DC Public Health Commissioner. So, I think I could be talking about both of them for quite some time, but I want them to be talking to you. Just to set the stage a little bit, so this topic, as we put it together and prepared, we wanted to really think about our audience today, and I think it'd be good to know who here works on the technology side of the cloud in a technical sense. Put your hands up. All right, who here works on healthcare, policy on the mission side? Okay, very good. Are there folks here who represent the community? Everyone's hands should go up there. But that's partly what we're talking about, right? And I think for us, our two guests today, they've done an incredible amount of work around population health, around health equity, around technology and innovation in healthcare, and health in all its threads: clinical, public health, policy, community engagement. And so, that really forms a thread of what we want to talk about, because right now, we're facing some major challenges, and we know that, right? If we think about it, COVID, we're still going through this pandemic. There have been so many lives, preventable lives, that have been lost. And I think, David, you and I were talking earlier about how when we look at the level of deaths that have occurred in life expectancy in the US versus Europe, for example, life expectancy has decreased 2 years in a row here. In Europe, it's going back up. That shouldn't be the case here. We've also talked, Reed, about just some of the challenges and opportunities around community engagement and meaningful community engagement. And I think that's where initiatives like AWS's Health Equity Initiative Grants Fund are meant to really help drive innovation and drive impact. And so the way that we're going to divide our talk today, we're going to first have our guests talk about some of the challenges they're seeing and some of the places where they see an opportunity for technology-enabled innovation. But that's going to touch on meaningful community engagement. It's going to touch on how do you look at infrastructure and building health infrastructure in all its flavors. We're also going to talk a little bit about trends such as, how we talk about the digital divide, right, or the continuum of access, however you want to call it. And then we're going to end with hopefully some guidance from our guests, some recommendations around what you all should be thinking about as builders, as innovators, as you work with the cloud, as you work with digital health, as you work with partners. So without further ado, let's start with David. David, if you want to talk a little bit about what you're doing and really how you see the challenge and the opportunity in this space.
Well, thank you, and thanks everyone for coming. And by the way, if you don't like what we're saying, the emergency exit is over there. Pleased to be here. So I'm a general internist. I was the inaugural chief medical officer at Rush, and my job was to improve quality within our health system. But in about 2014 or 15, we began to change our mission to improve health. And we made the issue of the life expectancy gap central to our work, the fact that you could live in the loop and live to be 85 years old, but 3 stops past Rush, life expectancy now, but unfortunately post-COVID, is under 66 years old, which is awful when you think about it. But to address life expectancy, you had to address the underlying social drivers of poor life expectancy, including structural racism and economic deprivation. So we aimed ourselves as a medical center to begin to think about how we could make a difference in that space. Of course, then COVID hit and exacerbated it. And the scale of the US problem is huge. 1 million deaths. If we were Australia, 100,000 people would have died. So if we were Canada, 500,000, even a giant number, but 1 million people died. 4% of the population in the world, 16% of the deaths. And unlike other countries, as Abdul said, life expectancy has not bounced back. In Europe, it has. So we've got a big problem, and part of it is a trust gap and access gap. And I think that's the work we're trying to do is to solve it. So as a medical center, we partner with other medical centers in the area, but in particular with the community, to begin to build solutions to the underpinnings of these death gaps.
Right, right. Thank you.
Carrying the ball forward, I think that this COVID experience is not only instructive, but it is also, unfortunately, determinant for what you do. This issue of trust and distrust is highly, highly significant. I wrote an article in Science that was published in Science about a year ago that talked about the disease of distrust. Mm-hmm. And essentially, it means that people who are distrustful of the society around them, who are distrustful of the systems with which they must interact, are very, very then unwilling to trust. Obviously, they're unwilling to follow guidance, especially even personally appropriate information, because of other factors and phenomenon. And so, what that means for this community, it means that you have got to be over-engineering that issue of trust and distrust. I think this is how do we gain it? How do we gather it? Let's just think for what we're up against now. So, we've learned from COVID that part of the reason why the Black community and other communities of color had such a disproportionate impact of death and disease from the COVID virus has been because of the jobs that we have, the engagement. We're on the front lines. We don't get to do Zoom calls to get us back out. But what we also found is that because of experiences like the Tuskegee syphilis study, which is still incredibly relevant in today's mind, even though most of the people who cite it don't even really know what it was. But they know that they're pissed. They know that something is wrong. And so you have to engage there. Then you start to realize that we've got the reason that people were so ill was because of multiple pre-existing health conditions. So now coming out of COVID, you see every meeting, social determinants of health equity built into it. Well, now all of a sudden we're moving with a new paradigm from traditional clinical care, worrying about the sick person, to moving upstream, worrying about other factors within the society. A whole new set of actors, a whole new set of data, a whole new set of players that must be kind of integrated. And then lastly I'll make as the comment is that we are in this moment where we are moving towards personalized medicine. Personalized medicine meaning very specific engagement of the individual with not only the clinical care system, but the medically important social determinants. Well, what does that mean? It means we're in a genomic era. My God, you mean to tell me that you're going to start having access to my genetic information? The same society that is trying to disenfranchise me from voter rolls all around the country, societies where they won't even let you collect race or ethnicity data because of the politics of the state, and you're going to look at my personal right? Not to mention all the upset and anger I have about vaccination. So you see the point. I love innovation. I love the new tools. Oh, it's just so exciting. You guys can do wonderful things. If y'all screw up the first principle, which is trust, trustworthy, and engagement with people like they're real partners, I guarantee you this will blow up in your faces, and we will have an even bigger divide in health, and especially at the micro level, a bigger divide in the digital divide.
Reed, well said. I know. And David, I want you to chime in here because I think it'll be good for the audience to know how you're engaging with the community to build that trust.
But I want to build on this. So think about that, what I said about the stats in the United States. So we all suffered because of this mistrust. It wasn't, we all suffered as a nation collectively. And the difference when I looked at Australia with a conservative government, the United States with a conservative government, 84% of people in Australia trusted the government, and the healthcare system in the United States is 34%. So what problem are we trying to solve? The problem of trust and the problem of systemic inequity. So when we looked at the life expectancy gap, the death gap in Chicago as being central to our work, a lot of people said, well, it's violence. Well, it's not just violence. We said it's structural violence. It's structural because it's designed into our laws, our policies, our procedures, our norms, and it's violence because people are harmed as a result. And the causes of death, even post-pandemic, cardiometabolic disease, of course COVID is in there now, cancer, account for about 50% of the life expectancy gap. Diseases for which healthcare should make a difference, but the mistrust is well-earned mistrust. We still have race-based calculators in our health systems that treat people differently based on race, from everything from kidney function to deliveries after a C-section. So we've got to sort of think about how do we solve for this problem. And the last thing I want to say.
Well, how are you doing that?
Well, the way that we're doing this, saying if we've had mistrust, and if we're part of the problem, how do we design care, for example, for cardiometabolic disease, and put the design of the care improvement in the hands of the patients and the communities that have the problem? Take hypertension, for example, as the #1 driver of cardiometabolic disease death. So we're trying to redesign healthcare from being a visit to the doctor's office to something that's done in the home. We know that 1/4 of Black and Latinx Americans have had a perceived discriminatory interaction with the healthcare system in the last year. What if we could take the care, have it designed by the community, have it being technology supported, and do it from the home? So that's our health equity analytics approach that we're trying to do, where we push out to patients' home, designed by the community, things like social needs screening, but also making sure people are understanding their medication and their diets, but taking the locus of treatment from the hospital and the clinic and moving it back into the community.
So Abdul wants us to keep pushing on, so what do you do? And so you're selling to, let's just say if you think about it, what is the people who are buying health data systems, what are they attempting to achieve? What's the point? Is it to look at the world like we've always looked at the world through our silo? Well, this is our hospital system, and the world revolves around our hospital system. Or is it through the perspective of the public health department and how they view it? Or is it through individual clinicians? Who is the customer ultimately for what has to occur, which is to create an integrated data architecture that doesn't silo information, wall it off so that it is not available in real time, so that it is only looking at retrospective analyses in a static way as opposed to a mobile, fluid way? Who is the end result? The end result has to be the patient, and it has to be at the level of the community. And those interests have to be built into the data architecture design. So I'm urging you strongly that as you work through the architectures, and that's what you're doing at AWS, as you work through the architectures to free up and liberate these poor trapped data that's locked into these silos, please make sure that you're doing it with the patient centricity in mind. I know that's tough from a business sale because the patient ain't buying it. The health plan is, the health system is, they are the customer. But what we've got to do then is all of us who are advocates for communities are going to have to put so much damn pressure from the bottom up on these entities that if they are not looking at it through that prism, they're going to suffer either in marketing, in consumer stickiness, reputational and brand enhancement, we're going to make it miserable. That's people like me. We're going to try to make it miserable for anybody who decides to continue to have Marcus Welby era perspectives on what data ought to be versus a modern, coordinated, comprehensive, integrated delivery system that merges together the social determinants of health players along with the clinical care people and other ancillaries so that there is this seamless movement of data across silos that people can trust. And finally, the data governance mechanisms. We're going to be insistent that we teach people of color about data governance and making sure that our voices are in that drama so that people don't continue to do biased data with biased algorithms for AI and machine learning that keep screwing over people of color.
Just to take this to the next level, like how do you design this? So you have to design around the people and the community needs. And that's not how things are designed right now. But think about who likes to go to the doctor's office. Nobody likes to go. But if we can design with community voice, so that's part of our intention that we have. We've gotten working with Amazon, AWS, but also Robert Wood Johnson, some other companies to build out a human-centric, community-centric, patient-designed technology to enhance the treatment, in our case, of cardiometabolic disease. I don't like going to the doctor's office. My doctor's in my own office, and I don't go to see her. But imagine then, and think about that visit. It's a 20-minute visit, and they're talking about like on the computer the whole time. It's not helpful to anyone. But but if you design it with people who've been most systemically excluded from health and healthcare, we're going to end up with solutions that are better for everyone. It's not the usual approach, but it's the approach we're taking in Chicago. And we're doing it starting at Rush, but this is going to be open source. So the solutions that we're creating are going to be given to other systems. So imagine you're at home, you've got hypertension, you take your blood pressure, that blood pressure measurement gets automatically sent to your doctor's office, your MR, wherever you are. It's agnostic to the health system, it's agnostic to the insurance, it's agnostic to the blood pressure device. And that's what we're trying to deal with. And then when people need help or need something, it's a push-pull system, but designed around people in their homes, where we can spend more time on the kinds of patient ed and the information that people need to manage their own health. So we talk about from bench to bedside. We're thinking about this design from community to the clinic rather than the other way around. And I think that's what's novel.
Starting with the community.
Starting with the community around the design. Now, I want to tell you why this is the right approach. People remember the Americans with Disability Act and the curb cuts. You've all seen curb cuts. They were designed for people with disability to be able to navigate the curbs, people in wheelchairs. But who benefits from that? Kids on bicycles, joggers, me pushing my grandkids in a baby carriage. We all benefit when we design around this. So we think this redesign is not only going to benefit these communities that have been systemically excluded from access, but broadly change the way that we deliver care.
Right.
Well, I think that opens up important sort of issues here so do you need another Americans for Disability Act hammer to get everybody to play nice together in this space? What's the role of the Office of the National Coordinator in this space? Now, a couple of years ago, before COVID, the hospitals and the big physician organizations complained that the pace was too fast for integration of interoperability. The dog ate my homework, and they got 230 Congress people to write letters to the ONC saying, slow down. In 2000, the National Academy of Medicine put together a report called Crossing the Quality Chasm. And the fundamental recommendation of an entire National Academy of Medicine report on quality said interoperability of data. 18 years later, hospitals and doctors are saying, I'm sorry, it's going too fast. This is too hard. It's too difficult. Yeah. Do we really want government to have to be the ones to step in and make rationality out of this? Or can the industry itself come together and make this sort of thing work? I'm a private sector person. From my background, you can tell. However, when it comes to being an advocate for people of color, I'm not sure that we can trust the private sector to move rapidly enough or intelligently enough. I want to be wrong on that. And so I'm really taking every opportunity, and Abdul, you know that, to really push the industry. And I don't mean just AWS. I don't mean just the manufacturers of EMRs. I'm talking all of our industry together who buy these tools. I'm on several boards for biotech companies. So I see it through the prism of clinical research. I see all these elements coming together. But we in the industry have got to decide to move faster. And the last thing I'll say on that is that there is a noticeable absence of passion about getting this stuff done in real time. And I'm watching people die every day at rates that are unconscionable as a result. So I really am urging a different kind of conversation.
This is a marriage. The same year, National Academy of Medicine, about the same time, wrote another book called Unequal Treatment. And these two ideas are connected. That oftentimes is inequality in quality, inequality in access that lead to these death gaps. These are human problems that are solvable. They've been solved to a certain degree in other places, to a greater degree than we have. And this data interoperability becomes central to it. You know, you can't, if you happen to go to one health system and get a blood pressure check, and now you go to another place, this data should be readily available across these systems. So you guys play a huge role in helping us think through these things. When you went into data science, you probably didn't think there was an issue of equity or justice in your work, but there is, and so solving these problems and how we solve it. We're up against, so we were talking this morning about the idea that we're on Epic EMR system, yet for a person to check their blood pressure at home using any cuff they want, get that result in, where a red flag might go up and say, we need to send a community health worker to your home, or we need to sort of figure out what's going on here, doesn't exist today. And we think that that's the chasm that can be crossed.
We have a couple of tools that we can build on. One is, let's definitely, and Abdul, I know you know this, and that's the tool of value-based reimbursement. Now that we get the delivery system out of the crazy fee-for-service, and hopefully that is almost completed, instead of having the delivery system continue to focus on sick people, now you make a significant financial incentive to go upstream and identify people early before that are at risk factors, before they tip into being sick, and then be able to engage them in not only individual health promotion and disease prevention, but community-based health promotion, disease prevention, to try to keep that person from becoming a lost leader on the economic side for the delivery system. That requires a different relationship between the clinical system and those things outside of the clinical paradigm. How do they connect? How do they talk to each other? That is a very important opportunity here that I think will be a driver. A second driver, I think, is the sense of what companies like AWS are in here, not the data side, but your consumer side. Consumerism in healthcare is now a full-blown revolution. That means individuals have to be competent to make choices, decisions, and use technology. Who knows more about how to get inside of somebody's head, regardless of race, ethnicity, or whatever? Amazon knows me. They love me. They are happy to see me every time I just type A in my browser. Boom. Hey, and it's me, and I'm logged in, and they tell me everything that I bought and everything I ought to buy.
Exactly.
They're wonderful about that. They're so nice to me.
Maybe I should chime in here.
Now, the question is, I'm getting ready to send a digital monitor for a serious health condition into a poor person's hands in the middle of South Central Los Angeles. And I'm going to try to find a way for that device to connect not only the device, that's half, the service.
Exactly.
The service. I'm going to connect that person with this device to a healthcare system that may or may not be prepared to handle them. But the one thing the health system is not prepared to do is to teach Mrs. Jones how to be competent with the device.
Yep.
Somebody else has got to do that. So here is this wonderful opportunity to bring the power of all these new deputies in healthcare, all these consumer-oriented companies in healthcare who have ridden in to save the Neanderthal traditional healthcare system with new competencies and ideas. This is a building block opportunity. So I'm urging you to do that. And the last thing I'm urging you really strongly to do. If you try to talk to genetics or an mRNA vaccine to most Americans, but certainly people of color, they have no idea of what you are talking about because it has never been discussed in any class they've ever had in school, because we suck when it comes to public education in America, and especially around science. My point is this. The whole world for any kid graduating today from high school is going to be a data-driven, integrated world. The competencies of being able to manage that data and the tools need to be taught. I am urging and begging this industry, with AWS as leaders, please, you've got to adopt your local secondary science teachers association and support real, rational, practical education in these schools, because our kids are going to be so far behind next year, they'll never be able to catch up.
Right. Thank you. Thank you, Reed. I want to get three things in. I know we're getting on time, and then I want to pass it to you, David, as well. No, you've mentioned some really important points there. Number one, please look up the AWS Health Equity Initiative. If you don't know, this is a $40 million three-year program of cloud credits and support, technical support. We have actually been funding multiple initiatives around doing exactly what you're describing, Reed, which is it's incumbent upon us, AWS, Amazon, and our partners, our SIs and ISV partners, you in the room and here at this conference, to really start building tools, services that drive progress against inequities and to address progress in health equity. Number two, I want to say that, when we think about what we're talking about today, we wouldn't have had a panel like this 4 years ago, 5 years ago, on a main stage at many conferences. And I think it's a different conversation now that we're having. And I think that's heartening, because I know many of you are having these same conversations. You wouldn't be here about how to address inequities in health through technology-enabled innovation. And that, I think, is something bears mention. We really are trying to bring a community together of innovators to make progress. I'll just highlight in the crowd, Louise Bellin at the back. He is the CEO of the National Health IT Collaborative for the Underserved. Many of you know him. Reed certainly does. But we've worked with NHIT and partners around developing a data fusion platform that brings publicly available data from HHS and other agencies together. But to be able to use that data to drive thoughtful intervention is where we want to go next. I think the third thing, and then I want to pass it over to you, David, to help us wrap, is I think we have to be comfortable being uncomfortable. This is a conversation where we should show passion. We should show emotion. And it's not just health equity, right? In our society, we need to be comfortable with a little discomfort. And that's how we're going to make progress. That's the only way progress happens. And I hope that our session will help you go onwards to be able to look at that. David.
All right, just to think about positive next steps. What do we talk about? There's mistrust. And then how do we really think about building mistrust? There has to be a federated approach to this, because we have fragmented systems and the solutions have to be interoperable. 3, design thinking around it, human-centered design, that people want that personalized approach to their own care. In the end, there are systems that oppress communities and people, but the solutions come down to what's best for me and my family. And I also think in my home. And I think if we can do that, but we need people in the field who are ready to design, think about equity as being central to your design, which means focusing first on those who've been most historically excluded and identifying solutions that are going to work best for them. They'll work best for everybody.
And in the last 10 seconds that I have, I would just say that we have talked a lot about policy, ethics, morality, and so forth. At the end of the day, let's make no mistake, this is good for business.
Really good.
Let's just be really clear. We have got to deal with the cost curve. You cannot deal with the cost curve if we keep doing what we've been doing before. We have to bring the cost escalation down, and everything that we have talked about are rate limiting steps that must be solved on the pathway to more cost-effective care. I just want to make sure that y'all didn't think that we had lost our mind and are not practical.
Thank you. On that note, thank you so much. Sorry we're over time. Have a great